Neurological emergencies. According to the National Center for Health Statistics, 2 of the top 10 causes of death in the United States in 2015 were neurologic. And from that, stroke is the 5th leading cause of death in the United States after heart disease and cancer. So when we're looking at neurological emergencies, we know it's focusing on issues with the brain. Therefore, you'll be seeing stroke, seizures, altered mental status, anything dealing with issues with the brain will be classed under that category. So we have to be mindful of these statistics, and as advanced EMTs, you'll be called to a lot of calls involving these emergencies. Hence, you need to ensure that you are first knowledgeable about the systems that are involved, which would be your nervous system, and especially you're going to focus on the pathophysiology, the problems that can affect the system, and then the signs and symptoms that you will encounter and how you will manage those situations. So as an advance, you have to have a deeper knowledge and be able to apply it. So as I mentioned, seizure will be one of the issues involving neurological emergencies, and it may occur as a result of recent or old head injury. It can be from brain tumor, metabolic problem, or genetic disposition. Your genes, you inherit it, and you have that as epilepsy. So be mindful of these causes and what can cause the seizure. But a lot of causes. As an advanced EMT, we're not going to be focused on all the causes and what exactly is happening, but is to be able to manage what is presented to you in the different cases. Altered mental status is a common presentation in patients with a wide variety of medical problems. So a whole host of issues can cause altered mental status. Again, it's not for us to diagnose the causes of which one is the issue, but it's to manage what is presented in the field. So possible causes range from alcohol intoxication, and it can go all the way up to head injury, to diabetic emergency, to stroke. So a whole host of things can cause altered mental status. So what we mean by altered mental status, you have what we call level of consciousness and orientation. Those are things that make up, two things that make up our mental status. Anything that affects our level of consciousness, anything that affects our orientation would be classed as altered mental status. So as long as the patient is not alert and oriented, then we would say they are having an altered mental status. Neurologic patients can be extremely vulnerable or even helpless. So we have to be their advocates. We are to ensure that we do what they cannot do for themselves. A stroke patient, they might not be able to manage their airway. We have to manage it for them. They might have weakness on one side. We have to protect their extremities. Otherwise, they will injure themselves, and we have to do what they cannot do for themselves. Very important. This is basically a review of the anatomy and physiology of the nervous system. You'd have looked at it before in your human body chapter, and also we mentioned it when we were doing head and spine injuries. So basically it's just a review, and you will see where this nervous system is divided into the central nervous system, which is the brain and the spinal cord, and also you have the peripheral nervous system, which would be the spinal nerves. Again, we see where the central nervous system, you have the autonomic nervous system and the somatic nervous system. So it's basically voluntary and involuntary actions control. Autonomic deals with involuntary actions. The somatic deals with voluntary. And you will see where signals are coming to and from the body via the spinal cord to the brain. You have motor nerves would carry signal from the brain to the rest of the body, and you have sensory nerves that would carry the sensation from the body to the brain. Like I said, this is just basically a review. So you have the nervous system is the most complex organ system within the human body. No matter how advanced a computer system man can make, they can never match up to the brain or the nervous system of the human. Very vast system. We don't even top maybe a quarter of it. So we say that you have brain, spinal cord, and nerve. So this nervous system, central nervous system, brain and spinal cord, the peripheral nervous system, the spinal nerves. What's the responsibility? It's responsible for fundamental functions. So it's most function is controlled by the nervous system. The major structures of the nervous system are divided into central nervous system and peripheral nervous system, as I said before. Again, this is basically a review. So the central nervous system, the main part is the brain, and the brain is divided into three main sections. We have the cerebrum, which we say is the major portion. You have the cerebellum, which is the secondary smaller section, and then you have the brainstem. Again, you need to know these areas, and easy way to remember which one is the main area is the smaller word cerebrum, refers to the larger portion of the brain, while the bigger word cerebellum refers to the smaller portion, and then you have the brainstem. Controls, what's the function of the brain? It controls breathing, speech, and all other body functions. So it is the brain box or the control center of the body. Brainstem controls the most basic functions. It controls our breathing, our blood pressure, swallowing, pupillary constriction. Those are done by the brainstem. So basic life functions controlled by the cerebellum deals with coordinating of movement, and the cerebrum is deals with speech, emotions, sight. Major things like those are controlled by the cerebrum. So we say that the cerebellum controls muscle and body coordination, and this we say is a smaller portion of the brain, while the bigger portion, which is cerebrum, is divided into the right and left cerebral hemispheres. The front part of the cerebrum controls emotion and thought, while the middle portion controls touch and movement, and also we have speech and for most persons on the left middle section of the cerebrum, while you have back section or the occipital area processes sight. These are things that you should have remembered from the previous chapters. When we look at the brain, messages sent to and from the brain travels through nerves, and you need to recognize that there are 12 cranial nerves that run directly from the brain to parts of the head. These cranial nerves does not go via the spinal cord. They go straight from the brain to the head and face and innervate them, and those are what gives you control for our senses. So sight, hearing, sense of smell, those are controlled by the cranial nerves. They bypass the spinal cord and go straight to the head and face. The rest of the nerves join in the spinal cord and exit through the brain through the foramen magnum, and we talked about that already. That's the opening. So basically the brainstem gonna be merging into the spinal cord. So the spinal cord would be like the bridge or the link between the brain and the rest of the spinal nerves. We need to recognize also that at each vertebrae in the neck and back, 2 nerves branch out, and these are nerves that we call the motor nerves and the sensory nerves. So they are pairs. One carries signal to the body, which will be the motor nerves, and then the sensory nerves relay back the information to the brain. So you always have a pair. Areas of skin sensation corresponding to specific spinal nerves are called dermatomes, and you need to know have an idea that we have these sensory points all along the body, which the nerves control, and so this is what gives rise to what we call referred pain and rebound tenderness, those sort of things, because you have the nerves all over the body. How are these signals transmitted? It's like an electrical pathway or chemical pathway. So you have the nerves, you have the neurons. These are what carry the impulses. So neurons and impulse transmission. Neurons are composed of 3 basic parts. So you have the cell body, you have the axon, and the dendrites. So the cell body is the main part of the neuron. Then you have axons, which will be the tail of it that relay the information to the next neuron, and then the dendrite would be at the head of it, which will collect the signal from the neurons ahead of it. And in between, you have the space or synapse, and you have chemicals or neurotransmitters are there to bridge that gap. So you have a continuous pathway of signals being transmitted. So interaction between 2 neurons occur at a synapse. Most neurons use neurotransmitters to transmit their signal across a synapse to other neurons. So just imagine you have this continuous pathway being maintained. That's how the signal is being transmitted or moved from the brain to the rest of the body, and also from the rest of the body to the brain. And here we see a diagram of it. So the neurotransmitters take the electrically conducted signal from one nerve cell, a neuron, and relay it to the next cell. So here we have the cell body, the neuron with the cell joint at the head, and the axon is the tail, and the axon would go to the dendrite of the next neuron, and you have a gap in between, which should be filled with the neurotransmitter. And so the signal is transmitted along that pathway all over the body. Now that we have looked at the anatomy and physiology, the main thing that we need to be focusing on now is the pathophysiology. What problems you can have with the system, and we're looking at the nervous system as we are looking at neurologic emergencies. What are the problems that can happen? You know how the system should work, or normally how it is working. What will happen when there are issues? And this is what you will see coming out from understanding the anatomy and physiology. Then you will know what signs and symptoms the patient will exhibit when they have certain issues. Many different disorders may cause neurologic symptoms and affect the patient's level of consciousness, speech, and voluntary muscle control. We say that the nervous system as the brain, and we say the brain control most or all functions of the body. So anything affecting it can show up in a whole range of problems and signs and symptoms. Other brain disorders include infection and tumor, may cause seizures, altered mental status, and headaches. A whole range of things we can see coming out. And again, it's not for us to diagnose which exact one, but you'll be managing the patient as they are presented, because most of the time it's going to be needing definitive care, surgery, diagnostic tests and checks to really determine which is the issue and to provide the definitive care that is ultimately needed. So as advanced personnel, we are going to be having our knowledge and managing what is presented and doing what's best for that patient to stabilize and treat them as appropriate as we can based on our protocols and scope of practice, and take them to where they can get a definitive care. So we need to recognize when we need to move, do what we need to do unseen, and know that at a point we have to move to get them to where they need to go. And time is very crucial in these neurological emergency cases. We say that time is brain, as just in a heart attack issue where we say time is heart muscle. One main pathophysiology we can have coming out from neurological emergency is stroke. And a stroke is an interruption of blood flow to the brain that results in the loss of function. So actually the stroke is a loss of function which is exhibited, and it arises from the CVA. So cardiovascular accident is what would give rise to the stroke, and that is the interruption of the blood flow is the cardiovascular accident, and then it plays out in the loss of function, which would actually be the stroke. So do not delay your response to a patient with a potential stroke. Again, we say time is brain. Once there's this issue, and we will see that you have different types of stroke, and it's gonna be, if it's hemorrhagic, then there's not much we can do. They need to get to where they can hopefully get that intervention done. And if ischemic stroke, again, it's all about time. You have to get them to that place where they can get the help as soon as possible. Without oxygen, brain cells cease to function and begin to die. We all know that within 4 to 6 minutes without oxygen, brain cell likely start to die. So as early as that, that's what we are looking at. Infarcted cells, dead cells, and once they are dead, they are dead. All right, so the idea is to stop that process before they reach that state where they are dead. They are ischemic, and if we can capture it and do what we can and get them to where they can get the definitive help to prevent those cells from dying. That's our aim as advanced personnel in the field. So here we have the stroke. We say is an interruption of cerebral blood flow may result from, so it can be caused from a thrombus, meaning that there's a blockage in the cerebral arteries, and just as how we have a heart attack where there's a blockage in the coronary artery, it's a similar thing we have happening in the brain. So it can cause some thrombus, which you say is a clot that is formed right there in the cerebral artery and obstruct the blood flow. It can cause complete occlusion, or it can diminish the blood flow, and you can have arterial rupture where there's a pressure buildup in the cerebral artery and they actually rupture, and so you have blood spilling into the area of the tissue and cause compression. They form clot eventually and cause compression of the brain tissue and affect their ability to get oxygen, to be oxygenated. The next cause of it can be from cerebral embolism. So there's a clot that is formed elsewhere, maybe in damaged heart, and it travels to the point where it's gonna lodge in the cerebral artery and cause obstruction. So it's gonna be referred to as ischemic stroke for thrombus and embolism, while if it's an arterial rupture, it is referred to as hemorrhagic stroke. Again, you could say that hemorrhagic stroke is more serious and the intervention are limited, but again, in the field as advanced personnel, you won't be able to determine which is which. So you will have to treat accordingly and get a patient where they can have that test done, which is you'd have to have a CT scan to identify, hopefully, if it's rule out hemorrhagic, and possible they can give them clot busting medication to break up the thrombus or the embolism. So time is very critical. Within 3 hours to 4.5 hours maximum is when the clot busting medication has a high potential for effectiveness. So again, is to recognize when that person was diagnosed with having issue, when was the last time they were normal, and identify that point and call it in, let the receiving facility know so they can prepare for that patient. So we say that ischemic stroke is when you have blood vessels blocked, so tissue distal to the blockage becomes ischemic. So once there's a blockage, there will be reduction in blood flow or complete seizure of cessation of blood flow to the affected area, and it becomes ischemic. Again, if it's not corrected, then those ischemic tissue or cells will eventually start to die. And the main reason is for it is atherosclerosis in the blood vessels is often the cause. So what is atherosclerosis? Is a buildup of calcium and cholesterol buildup, which reduce the size of the lumen and ultimately reduce the flow of blood. Again, we say it can reach the point that it's a complete occlusion, and no blood flow means no oxygen to those cells that are distal, and that's the issue. Again, we say the loss of movement on the opposite side of the body is gonna be resulting from that reduction in blood flow, and the patient will start to be anxious, get confused. As the condition worsens, they can lose their ability to speak. Again, it depends on which section of the brain is affected. We said the cerebrum control emotion, thought, vision, speech. So it all depends on which area is affected. And we mentioned before that you have the left and right hemisphere. So the left hemisphere controls the right side of the body and vice versa. Cerebral embolism could block blood flow. Patient may experience anything from a few symptoms to complete paralysis. So it all depends on the extent of the blockage, the extent of the area of the brain that is affected. You will have varying degree of signs and symptoms resulting from this issue. For hemorrhagic stroke, it's gonna result in from the cerebral rupture, we said, and it will result in bleeding inside the brain, and this bleeding will result in clot formation and cause compression of the brain tissue, and so those cells now are not able to be properly oxygenated, and the same issue, ischemia. Eventually, if they are not controlled, the situation is not controlled, those cells will start to die. And so hemorrhagic stroke often is fatal, lethal. Chances of their recovering or surviving is slim. Symptoms: sudden onset of a severe headache, rapidly decreasing LOC. As long as that bleeding is not checked, then they will continue to decrease in their level of consciousness, and like we say, eventually death will result. And we come back to the issue of intracranial pressure. We said that the brain is in a vault, the skull is a vault. The only opening we say is the foramen magnum. So once that pressure, once the bleeding start and the pressure start to build up, then there's no way of relieving that pressure. It's gonna continue increase, and you can have it raise to the point that tissues are so affected by that compression of the intracranial pressure, and you can have the brain shift to try to accommodate the pressure, and eventually it will move to the foramen magnum where you have herniation. So with increased ICP, brain may become ischemic, herniate, a shift of the intracranial contents within the cranial vault. As ICP rises, the amount of blood available to the brain decreases, and we have to understand what is happening here. Once the pressure starts to increase in the brain, the sympathetic nervous system will be stimulated to compensate for the loss of oxygen to the cells. To send more oxygen there, it will stimulate the sympathetic nervous system, which is a speed up things, so the heart rate will increase, respiration will increase, and blood pressure will increase as a result. Now, once this happens, once the blood pressure increases, the sympathetic nervous system will come in after a period of time to try to lower that blood pressure, and in so doing, you will have the heart rate going to lessen. So the heart rate will reduce, and so the patient will become bradycardic. And as the condition get worsens with the intracranial pressure, it will affect the brainstem where the respiration will be affected. So you have irregular respiration. So that is what's gonna give rise to the Cushing triad. You will have bradycardia. So instead of the normal condition you have in shock, where you have hypotension and tachycardia, you will have in this case it will be hypertension, elevation of the blood pressure, and also you will have bradycardia with that irregular respiratory rate. You will have increasing rates of respiration. Maybe at some point it will go to apnea, and that is what will be happening. Again, this is gonna happen after a time. So in the early stage, you might have the patient actually having tachycardia, but once the compensator mechanism start to go the other way, then this parasympathetic nervous system is gonna come in, and you might actually find the patient after a time with bradycardia, hypertension, and that irregular pattern of respiration. Those are the classic signs you know that they are in that advanced state of intracranial, raised intracranial pressure, and you will even have their pupillary reaction being affected, where they have an equal pupil size because of that compression of the brain. So once there is normal condition in the brain with the relation to the blood, the cerebrospinal fluid, there is no compression, then you will have that normal smooth roundness of the brain in its normal anatomical position. The cerebrospinal fluid encased around it in the meninges, and the blood around it also. Once there's a condition where the pressure going to increase, once you start having intracranial pressure increases, then you will find that if it's a shift, brain volume increases, example from a tumor, then the blood and the cerebrospinal fluid will be compressed, and ultimately that is caused from the enlargement of the brain. But also, if you have blood volume increases in case of a hematoma where there's a bleeding, subarachnoid hemorrhage, then it's gonna cause the compression of the brain and the cerebrospinal fluid in this case. And so in both cases, you will have raised intracranial pressure can result, and you will see the same signs developing over a period of time if it's not controlled. We will have a case where the conditions of stroke are resolved within 24 hours. So there could have been a blockage, and it has been, body normal processes break it up, and so circulation is restored to the affected area, and so the patient would have been experiencing some loss of function before you arrive, or even you would have catch them at that point, but eventually it clears up within 24 hours. We refer to that as a transient ischemic attack, TIA. So it's like what we call a mini stroke. Again, this is a warning sign that a larger full stroke is imminent. So there's a condition there. They can be having a clot there, some thrombus there. So it could be that it can occur again, and at a worse state now where they can get a full-blown stroke. So each condition is resolved when you reach there or after you're there. Encourage that patient to go in for further assessment. Very important. What are the signs and symptoms we will see coming out of stroke? We say that a whole range of things can happen because of the area of the brain that is affected. So think of anything that normally would be working can be affected. So you can have facial drooping, sudden weakness or numbness, hemiparesis, You can have decreased or absent movement and sensation on one side of the body. Ataxia, coordination of movement is affected. Sudden vision loss, we said that the occipital area of the brain control sight. So if that's the area that is affected, then you can affect our vision. The person's vision can be affected. And you have a whole range of things can happen. You can have dysphagia. They can have difficulty swallowing. They can have decreased level of responsiveness. Again, we say altered mental status is a whole range of things. They can the orientation can be affected, which they will have confusion, dizziness. It can go all the way to coma, total unresponsiveness. They can have aphasia, which their ability to comprehend or express themselves. So we say that they left most persons they left middle section of the brain control speech, and they can have the movement of the muscles that control speech can be affected, and so they can have slurred speech. They can have sudden and severe headache because of the compression of the brain tissue. So a whole range of things can happen. Anything you can think about that the brain would normally control, if there's a stroke, it can affect any one of those functions depending on where the issue is occurring. And again, we say you have right hemisphere control the left side. So left hemisphere problems may cause aphasia, paralysis of the right side of the body, because we say the left hemisphere, the brain speech is controlled in most persons on the left side of the brain. So if they are having left hemisphere problem, it can affect their ability to express themselves or to understand when you talk to them. Paralysis of the right side of the body. So we say the left hemisphere control the right side of the body. So they would have right-sided weakness. Then you would thinking of left hemisphere problem. If they're having right hemisphere problems, then it will affect the left side of the body. And so you can have paralysis of the left side of the body. And words may be slowed and hard to understand. So this is dealing with the motor part of the speech. That will be controlled on the right hemisphere. Bleeding in the brain, intracerebral hemorrhage, and may present with hypertension. As I said before, because of the sympathetic nervous system being triggered to compensate for that reduced blood flow and oxygenation of the tissue, it will cause the heart rate to go up and ultimately increase the blood pressure will elevate. So conditions similar to stroke, we have to be mindful of these conditions. You will have patient exhibiting these conditions, and we assume that they are having a stroke, and sometimes we'll overlook the fact that they can be having these underlying issues. So be mindful of it, that a person is having symptoms of a stroke, then think that it could be that this patient is hypoglycemic. Their glucose level could be low. So again, once you're assessing them for that stroke, then you should also do a glucose test to rule out hypoglycemia. They can be in the post-ictal state, and again, it will mimic signs of stroke, and also they could be having that subdural or epidural bleeding. Again, it's the same physiology gonna be happening. The our pathophysiology, the compression gonna be occurring just the same with the brain tissue, and it will give rise to the same symptoms as a stroke. Be mindful of that. Don't just tell yourself that it's a stroke, and recognize that it can be similar in other cases. So do a full assessment of your patient, and then go along with wherever the assessment leads you, then you take it in that direction. So conditions that may mimic stroke, we said it can be a person having subdural bleeding and epidural bleeding, and this usually occur as a result of trauma. So once there is trauma to the head, and then they suspect that the mechanism of injury could be a case where they can be having subdural bleeding, then don't just have a tunnel vision and say that it's just the blockage that is causing it, which would just be a stroke condition. With subdural and epidural bleeding, the onset of stroke-like signs and symptoms may be subtle. So for the subdural, it will take a longer time because those are the bridging veins that are normally affected. So it will take a longer time to develop. But also for the epidural, might develop a little faster, but you might miss those signs and symptoms, and don't be tunnel vision. For seizures, so we are talking about neurological emergencies and seizures. One issues that can arise, and what is causing the seizure? It's a sudden erratic firing of the neurons. So it's like the neurons are out of control; they are doing their own thing, and this gives rise to the effects that the seizure. So patients experience a wide array of signs and symptoms when having seizures. It can be limited to one hand shaking or a metallic taste in the mouth, or involve the movement of every limb or complete loss of consciousness. So you have the categories of generalized grand mal, or you can have the focal petite mal, and you can have partial seizure. So there we have the classifications of seizure. They group as generalized, where you have that tonic-clonic, formerly called a grand mal, and in this case you have the full body violent jerking movement. So you have the tonic where you have that rigidity, and then the clonic is where you have the shaking or jerking, and you can have absence, formerly called petite mal. In this case, you have the patient might just be staring, and then you also have seizures, which is related to a psychiatric mechanism. So you still have the tonic clonic, but it's caused by a psychiatric mechanism. The patient is not faking it, so don't tell them that they are, or just tell yourself that, assume that they are faking it. They are having an issue. You also have so it's not, if it's not generalized, it can also be partial, where it's not involving the brain, but just a particular area, where you have shaking of the area of the body in the simple partial and sensation in one area of the body, while in the complex partial, it's actually affect the person level of consciousness. So you know the difference in the groupings and classifications and how they can present. Common causes of seizures, and we need to pay attention and make sure that these are all a range of things that can give rise to a seizure. Again, it's a wide array, so it's anything that can trigger that erratic action of the neurons. You can have an abscess that cause that, alcohol, birth anomalies, persons genetically develop it, brain infection, meningitis, encephalitis. You can have brain trauma, diabetes mellitus, fever, rapid rate of rise. So once the temperature elevate rapidly, it can give rise to seizure. We have in children, you have the febrile seizure, hypertension during pregnancy, eclampsia, another serious issue potentially. It can be idiopathic, no known cause. They just have it. Inappropriate medication usage, organic brain syndromes, recreational drug use, stroke or TIA, systemic infection can give rise to seizure also, tumor and uremia, where you have kidney failure and you have the waste become remaining in the blood, and that can give rise to seizures. So we see a whole range of things that can cause seizures. Again, it's not really us to diagnose which is which, but we will treat the patient as they are presented and do our assessment and manage them accordingly. So it's very important that we recognize the possibility of the seizure and recognize when a seizure is occurring or has occurred and whether this episode differs from previous ones. We need to be mindful of when they are in the post-ictal state and complications of the seizure, and look at other problems associated with seizure. So to be mindful that they can be having other underlying issues. We can't have a tunnel vision and just be focusing on the fact that they're having a seizure. They could be having other underlying issues. They could be having cardiac issues. They can be having other issues. So be careful of not being tunnel vision and focusing on just the seizure episode that they are having. So when they are in the post-ictal state, it's gonna be characterized that they will normally start out with that tonic-clonic phase, and that normally lasts typically for 3 to 5 minutes. After that, typically they would get tired and become flaccid. The patient muscle will relax, and basically the shaking and tonic-clonic activity would have stopped, and they are in that state now. They can remain in post-ictal state for up to 5, even 30 minutes. So it's in that state that we say sometimes it can be associated or mimic a stroke. So post-ictal state may be characterized by hemiparesis. They will be having weakness on one side or weakness on one's resembling a stroke. So don't be tunnel vision. Most commonly characterized by lethargy and confusion. So they would have used up a lot of energy during the period of the tonic-clonic activity, the shaking and excessive movement. So the patient may be combative also. Again, it's all about protecting them from further harm, managing their airway. They might be in a state of altered mental status before they fully recover from that episode. So again, treat them accordingly. All right, we talk about altered mental status is a wide range of signs and symptoms and presentation. So anything from not being, once a person is not alert and oriented, then we are saying that they would have varying degrees of altered mental status. So a patient who is not thinking clearly or who is not capable of being aroused. Patient may be unresponsive, responsive but confused. So any degree of not being alert and oriented would put that person in altered mental status category. So how are we going to deal with that? And so causes include hypoglycemia. So it can be from low glucose level. It can be from hypoxemia, low oxygen in the blood. It can be from intoxication, drug overdose, unrecognized head injury, brain infection, body temperature abnormalities. So a whole range of things can be causing this altered mental status. Other causes can also be hypoxia, unrecognized head injury, severe alcohol or drug intoxication, psychological causes and adverse effects of medications. So a whole range of things can cause this altered mental status, cause these patients to be not alert, not oriented. Another neurological emergency that we can be called to a patient having syncope, and this is where they are fainting. This is a sudden and temporary loss of consciousness with accompanying loss of postural tone. So they just become just weak and flaccid and just collapse. Potential causes: problems with cardiac rhythm and conduction, problems with cardiac muscle, myocardial infarction, dehydration, hypoglycemia, vasovagal episode. So they just can have a triggering of their vagal nerve, and the heart rate gonna drop significantly. Output will be affected, and so blood flow, oxygenation to the brain affected, and they just faint. So anything that causes a temporary reduction of blood flow to the brain and oxygenation then can result in that syncope. But most of the time, once they hit the ground, they will come back, they will recover, and that's the episode of syncope or fainting. Again, it's indicative, can be indicating a more serious issue. So again, these patients would encourage them to have them checked out for other underlying issues or worsening problems. As it relates to headaches by themselves usually are not life-threatening, but you can have headaches that are severe and associated with other signs and symptoms that can be potentially life-threatening or indicating a life-threatening condition. So the normal range of headaches, you would have tension headaches caused by muscle contraction in the head and neck and are attributed to stress. So normally there are no pressure receptors in the brain, but what happens and surrounding areas can give rise to the headache, and that is what we see coming out for a tension headache is actually muscles that are contracting in the head and neck and attributed to the stress, and so it gives rise to the headache. Another type of headache would be migraine headache. Again, we say it's not any pressure pain receptor in the brain, but is caused by changes in the blood vessel size in the base of the brain, and again that gives rise to the headache. You can have cluster headaches, rare vascular headaches that occur in groups. And so we say normally these headaches are not life-threatening, but they can be indicating and that there is possible other underlying issue, and especially when you have other symptoms occurring with them, and especially when they are severe, then you know about subarachnoid hemorrhage or sudden onset of headache, severe headache, then you have to think those as potentially life-threatening. How do we assess these patients generally? So patient assessment will always be patient assessment generally. You're going to start with your scene size up, your primary survey or primary assessment. You go down through your history taking, secondary assessment, and your assessment. So basic concept will always be there with just a focus on the specific areas as it relates to neurological emergencies. So the brain is sensitive to fluctuating levels of oxygen, glucose, and temperature. So once it is gone to a certain level, it can affect the brain, and so you have to relatively resilient to internal environmental changes. It can tolerate so much and no more. After that, it will start to be affected. Key to identifying a neurologic problem is to look for both obvious and subtle changes. So, and those are the ones that we normally miss. The subtle ones, there are changes there that we don't really pick up, and it can give rise to life-threatening conditions being there and prolonged before the patient is assisted or assessed properly. So we say that every patient assessment will start with our scene size up. Take standard precautions. Again, with neurological emergencies, can be a case where patient can be combative, and so if you think that condition merit that you call for backup, you get backup, and you must take your standard precautions. So first, we must ensure that that scene is safe. Whatever you consider is likely an issue that can affect you, your partner, patient, family members, you must rule out that first before you enter any scene. Safety will always be first and foremost. Once you have ensured that the scene is safe, then you're going to want to check and see what is the mechanism of injury, in this case, and nature of illness we are looking at. Have an idea of what is going on. You'd have gotten your information from dispatch, but always when you go on the scene, you're going to determine what is really happening here. So you will look for clues at the scene as to what may have happened. Once you're on that scene, that's where you're gonna determine that true NOI. And again, we say it can be MOI can be there also, so don't have a tunnel vision. Ensure that you have an open mind and recognize that patient could have sustained trauma and also combination. So consider MOI or history of present illness, and also consider if there's possibility of spinal injury, then you need to take that precaution as you go forward in your assessment. If nearest stroke center is greater than 1 hour away, request air medical transport early if possible, if available. So from the outset, you must be thinking from what you have gathered from your NOI or MOI determination, you consider that this case is gonna merit longer time to reach, and you will know that we're thinking about stroke condition. They need time is brain, so you need to get them as soon as possible to the definitive care where they can get clot busting medication if that's indicated. Then you need to request your medical transport if it's available in your jurisdiction. Also, you're an advanced personnel. If your case is gonna be bigger than you, then you need to call for that paramedic backup if it's available in your jurisdiction. But you must do a proper scene size up. Safety first. Determine your NOI, MOI if indicated or possible. Consider spinal injury if that's possible or indicated. You take your standard precautions. Make sure that you fully protect yourself, and you determine how many patients. Consider the need for additional resources and call for them early, especially if you need paramedic backup and you think that you need to get your support, then you call for them early. It's better to call and you don't need them, you can turn them back rather than wait until it's late and then you're calling for them late. So after you have completed your scene size up, you will always go to your primary survey. So for the primary survey, it's always gonna be getting that general impression of your patient. You need to, from the outset, have an idea of how stable this patient is just by looking, and you also will move to your level of consciousness check along with manual stabilization. If you had suspected spinal injury, then you're gonna move down to your A, B, C, D, E. And if there's possible bleeding, if trauma involved and bleeding, exsanguinating, then it's gonna be your X, A, B, C, D, E. Again, form a general impression, determine LOC for anyone with altered mental status. You're gonna determine it for every patient, but more so you're gonna need to get that baseline LOC for your patient with that neurological emergency. It's very important. Altered mental status, you need to know from the beginning what is that status, and you need to recognize that abnormal posturing may indicate severe brain dysfunction. So we looked at this in head and spine injury. The two posturing you will notice is the corticate and the cerebrate, and easy way we say to remember them: core. They pull into the core, so flex to the core. That's the corticate. That's a less dangerous condition than if they are in the cerebrate position where they are extending, they become flaccid, they are extending themselves. That's a worse condition. Again, that is showing serious brain issue. So as you continue your primary survey, once you have determined the LOC and taken the spinal precaution if indicated, then you move to your A, B, C, D, E, we said, and focus on airway management, breathing. These patients, sometimes they are not able to manage their airway on their own, they are not able to control their airway, so we will have to provide that support for them. You have to ensure that you are managing their airway for them if it's needed, and their suction if needed, position the patient if needed to get rid of secretion, maintaining manual stabilization if it's needed, and also position the patient to prevent aspiration. So you might have to put them in the recovery position if they are able to maintain themselves. Provide ventilator support to at 10 to 12 breaths per minute. So 1 breath every 5 to 6 seconds. If they need ventilatory support, again, assess and treat accordingly. You would, as an advance, you would put on your end-tidal CO2 monitor. You need to get that capnography reading, and also you pulse oximetry, listen to lung sounds. For you, after you have completed managing the airway and breathing, ensure that you have dealt with any issues. Then you need to check circulation. Again, if no pulse is found, immediately begin cardiopulmonary resuscitation, or if you need to do rescue breathing. Vital signs will provide evidence of increased pressure within the cranium. As it relates to your advanced, patients can be having cardiac issue, so it's a good thing to put on your, attach them to the cardiac monitor, because they might be having heart issue, which you need to try and assess and pick up what's going on. For circulation, if it's a condition where they're hypotensive, you will consider your IV access and fluid resuscitation based on your protocols. At the end of your primary survey, you would have determined the transport priority of your patient. So you would have completed your ABCs, you would have done your check of disability, GCS, ensure at this point you should have gotten the GCS of your patient, and also expose, and if you need to do a rapid scan, then you would have done your rapid scan. And remember, if you expose, you need to recover, and you would have made your transport decision based on what you have discovered so far. Unstable patient with inadequate or deteriorating ABCs should be transported immediately. Again, we say there's so much we can do in the field for these patients. They need to go and get definitive care. Once they're having a life-threatening emergency condition, then we have to limit that unseen time and get them to where they will need to get the treatment that they needed, and call ahead to alert the centers. If you have a stroke patient, you need to alert the stroke center that you're coming in with the patient, because they need to get the relevant personnel to be ready by the time you reach. Again, we say time is brain. Focus on stabilizing and maintaining ABCs. So that's the most we can do in most cases. Stabilize and maintain the ABCs, package them and transport them appropriately to the receiving facility where they can get that care that they really need. Once you have completed your primary survey, then you would have reached to your history taking. And for your conscious patient, you want to get that history as quick as possible before that patient become altered or unresponsive, totally unresponsive. So you're going to investigate the chief complaint. Once you complete history taking, it is investigate the chief complaint first, history of the present illness, which you're going to use your OPQRST mainly to get that information, and all the relevant questions you need to ask depending on the situation. And also you will get a sample history, but history of the present illness first, then you move to your sample history. So obtain history from patient in stable condition. If the patient is unresponsive, gather any history of the present illness from family or bystanders. So not because the patient is unresponsive, you say you can't get any history. Again, you can get what you can from family members and bystander. In main case, you want to know when was the patient last seen normal, and also the patient can have medical alert tags or bracelet that can clue you in as to what their conditions are. Therefore, you try and get that history as best as you can. Evaluate the patient's speech, look for any obvious trauma, get a sample history. So if you're considering that the patient having a stroke, you're gonna do your stroke test, and the main one we use is your Cincinnati stroke test, where you test their test for facial droop, arm drift, and speech. So you need to have an idea of that also. and you need to ensure that you have gotten the patient GCS. Those are important findings that you need to get. After you have done your history taking, or sometimes we combine them, depends on the team that you have available. The team leader would have been getting that history, while the assistant secondary person could be doing the vital signs, which you need to be doing in your secondary assessment. So for your secondary assessment, you're going to perform a secondary assessment as soon as possible. Again, it is to see whatever you'd have missed in the primary while you're focusing on the life checks, ABCs. Then you're going to be searching now to see if there is anything else there that could clue you in as to what's happening to the patient. And so you're going to look for potential cause of neurologic signs and symptoms, assess for injuries. Rapid identification of a stroke is imperative. Use common stroke assessment tools. So it is not going to determine whether it's ischemic or hemorrhagic, but it's to recognize that there's a possible stroke situation here, and you need to make sure you package that patient and move them to the place that they can get that definitive care. And again, you would have done your vital signs, so it's important that you would have done your vital signs as a part of your secondary assessment. So you need to have those primary vital signs. We say we have about 7 of them. So you're going to go back to LOC, orientation. You're going to check pupillary reaction, respiration, blood pressure, pulse, and skin condition. All of those will be included on your GMR if indicated. So you know that you have your complete list of vital signs that you must assess. And the last part of your patient assessment would be your reassessment. So after you have completed all of your scene size up, primary survey, history taking, secondary assessment, by this you'll be en route with the patient. You'd have called the receiving facility, giving them what condition of your patient, and you'll be on your way. You'll be following up on your patient. You need to see what's happening with your patient, either they are improving or they are getting worse. So it's gonna be every 5 minutes you're gonna reassess a critical patient or unstable patient. Every 15 minutes you're gonna reassess a stable patient, but you must do a reassessment. You're not gonna be just driving in that ambulance, just waiting to reach the hospital or the facility without continuing monitoring and checking your patient. So intended to closely reassess ABC. So basically in your reassessment, what you're doing is repeating what you have done, all you have done before for your patient. So you're gonna go back to your primary assessment. You're gonna go back to LOC check. You need to know what's happening to your patient now. The baseline LOC that you have gotten before, you need to see what is it now. GCS, check back and see what is GCS score is now. You're gonna check back on your ABCs, chief complaint, vital signs, and interventions. Whatever intervention you have done for the patient, check back and make sure that they are still working, they are still effective. Monitor patients for changes. Anything that you see need to be corrected, you correct it. Anything that is not working, you address it. If you find any new problems, then you have to deal with them. Routine monitoring should include heart rate, blood pressure, respiratory rate and pattern, pulse oximetry, glucose level reading, GCS scores. So you need to ensure that the patient is on that cardiac monitor. You need to ensure that you're getting that entitled CO2 capnography reading. Again, you need to, if it's indicated, you need to check their glucose level, ensure that you follow up on the GCS score and check it at interval to see if there's any changes, and you need to record all these things because you will be the eyes and the ears for the physician. A lot of things they will not know when you reach there, so you'll have to give them that information so they can have a better idea of what is going on and can provide that ultimate care that the patient needs. So you have to document all these things. Very important. always provide emotional support. These patients will be anxious, and so we have to be advocate for them. You have to reassure them. Don't be judgmental. No matter what's happening to that patient. Patients who are having stroke, they can be incontinent. We're not gonna be judgmental. We have to reassure them, encourage them, do the best for them. Notify the receiving facility of your patient's chief complaint and their assessment findings. Document your findings and interventions. Document the onset and duration of the seizure, especially for the stroke condition. It's very important that the receiving facility is aware of when the person was last seen normal. A person, you would have asked when the person was last seen normal, and they say they woke up and they saw them like that. But that is not the answer. The answer would have been they would have been seen normal from the night they went to bed. So that's the thing you would have to say. Last normal would be when they went to bed. So it's a big difference. So make sure you get the information as accurate and best as possible, because it will determine what treatment they can get based on the time frame that they have been like that. As it relates to specific emergency care for the different neurological emergencies, a patient with stroke, seizure, hypoglycemia, or hypoxia shows identifiable signs and symptoms. So its best treatment is determined by performing a thorough assessment and maintaining the ABCs. So again, the general approach will be the same for patient assessment, but you're gonna be specific in these specific cases. So medications available for pre-hospital treatment of hypoglycemia would be our dextrose and the glucagon. So you're gonna be ensuring that you check the person glucose level, because these condition hypoglycemia can be resulting in those conditions also. So it is also important that you check that glucose level and provide the necessary treatment based on your protocols. Hypoglycemia is more lethal than hypoglycemia is more lethal than hyperglycemia. So with hypoglycemia, you will go into insulin or diabetic shock, while for hyperglycemia, the person will go into coma, and it normally takes a longer time for the effects of the hyperglycemia to be felt, but for the hypoglycemia, it's almost sudden, instantly. And just as how the condition comes on suddenly, the treatment will act just as fast. So you give the person who is hypoglycemic the glucose or dextrose, and they will recover instantly. It's like a miracle, you work right away. Ensure that the IV line is patent before you attempt to give the D50 or the dextrose. Ensure patients do not aspirate, and that's why you will not give a person, the textbook will say, once the person cannot coordinate, they cannot manage their airway, then we will not give them anything by mouth. That's the textbook answer. No safe way to lower a high blood glucose level in the field. So as I said, the treatment for the hyperglycemia is gonna be a long process, and so we are not gonna be treating that in the field. It's just to provide that supportive care, manage the person's ABCs, and transport them to where they can get that definitive care. Emergency medical care as it relates to stroke, administer supplemental oxygen. So again, we're gonna go through our patient assessment just the same, A, B, C, D, E. Administer supplemental oxygen if it's indicated, establish IV access, and obtain blood samples for analysis. Follow your protocols. Also, if they are having signs of hypotension, then you would have to establish IV access and give that fluid resuscitation according to your protocols. Unless you are concerned about possible spinal injury, elevate the patient's head 30 degrees. This will help in the case of the raised intracranial pressure, and so it will help with blood flow, venous return, and also with any CHF drainage, and basically help the patient manage in a more comfortable position. Ensure that the airway is clear, watch for seizures, and call early for paramedic backup. We can't overemphasize that. Again, based on your jurisdiction, because most jurisdiction, you will not be having any paramedics coming, so you will have to do what you can do and get the person as quick as possible to that definitive care. But where possible, you call for that backup as once you recognize that it is potentially needed. And you can look at this diagram. It's basically telling you the different areas that you go through as it relates to pre-hospital, in hospital, when the person is having these situation, adult suspected of stroke. There is best outcome for them is when these parameters are followed and the time frames are critical. So once they reach the hospital, they have a certain time where they have to test them, do a CT scan, and give them that clot busting medication as indicated. And also we have our time frame. We have to do our assessment and get them to the definitive care within that time. So time is brain. Very important that you recognize that, and just what we have to do, stabilize their ABCs, package them appropriately, and move with them. Notify the receiving facility so that they can prepare for them and have that window, that time period dealt with so that they can get the best outcome. That's what our aim is, to be advocates for a patient, to do what's best for them. For transient ischemic attack, that's basically the symptoms might resolve. So most of the time you just need supportive care. So begin with standard care, follow same management guideline as for a stroke. Again, we might not know at the beginning that it's a TIA, so we're gonna treat them just as if it's a full stroke, and then we will see how it goes. So close neurologic assessment is needed. Strongly encourage patient to be transported. So if the symptoms would have resolved while you were there, after or it happened before you reached there, then you're still gonna encourage a person to go and have it checked out, because it could be a fact that there's an underlying issue that is there, and they might still come and have a full-blown stroke after you have left them. So reinforce that TIA is a warning sign of a serious or fatal problem. Emergency medical care as it relates to seizures. We say that it's erratic firing of the neurons. So patient will present with that tonic-clonic, and then you go into the post-ictal state if a generalized seizure. So you want to, they will require definitive evaluation and treatment at the hospital, but we are gonna give them that supportive care for the ABCs. So if they need oxygen, we oxygenate them. If they need to provide positive pressure ventilation, we do so. If we need to suction them, we do so, because we said in that post-ictal state, they will lose control. They would have been lethargic after that energy being expended in the shaking and that seizure activity. And so you would have to ensure that you provide for their ABCs, manage their ABCs, and transport quickly to the hospital. Gain heavy access as a medication route, and depending on local protocol, you should assess and treat the patient for possible hypoglycemia. So once a person have any altered mental status, the rule of thumb is that it can be from low glucose level. So we should be checking their glucose level. That's the general rule. Any altered mental status, person found and you don't know what happened, then you can suspect that they can be hypoglycemic. So check their glucose level. For syncope, determine whether the patient experienced trauma during the fall. So again, if you suspect that, then you will take precaution to protect their spine. Focus on blood glucose level and likely cardiac causes. Those are the two big ones that would promote the syncope episode. So again, you'd have to connect your cardiac monitor and check their heart readings. provide supplemental oxygen and gain IV access. Again, they might have the hypotensive, so you might have to give fluids. Syncope can be a sign of life-threatening medical condition. So even though they will hit the ground and come back up all right, then consider that again, just like the TIA, it can be an indication of a life-threatening condition that needs to be addressed. As it relates to headache, we say most of the time it is not a life-threatening condition, but there are cases where severe sudden headache with other symptoms can be indicating that it's a serious problem, and so we cannot just rule it out and say it's all right. So give standard care, manage their ABC as always, ask patients about medications. Many patients appreciate a darkened or quiet environment. Do not use lights or sirens when transporting them. So that headache in itself, if you use that light siren, it's gonna make their condition worse and impact them negatively. And if it's a migraine headache, worst case, they are cannot tolerate they're sensitive to light. So be mindful of that. And you would have come to the end of this presentation on neurologic emergencies. Any questions? Mr. Bradshaw?